Before I start my talk, I wanted to highlight two featured trials, and actually for the holiday season, this is a buy one get one free featured trial. So the first is reduced lap HF, and the second trial is, actually, if you can forward to the next slide, is alt flow, and then maybe go back to reduce HF. So these are two trials looking at intra-atrial shunt devices and addressing the fact that much of the obviously exertional dyspnea that comes with heart failure is related to increased left atrial pressure with exercise. So both of these trials are looking at intra-atrial shunts that are meant to function as pop-off valves for the left atrium in the setting of exercise. The first device, the Reduce HF device, is made by Corvia Medical, and that's the one that has more clinical data to date. This trial is looking only at patients with heart failure with preserved ejection fraction. And the other trial, the alt flow trial, Dr. Siraj is actually the international primary investigator for that, principal investigator. And this device, we think, has some advantages in terms of the way it's deployed. And we think in that respect may be a better device. So when actually you refer patients for consideration for these trials, Jane Fox is the research coordinator for both, and we're simultaneously screening for both trials. And with a preference to this study, the alt flow study, which actually can look at patients with both diastolic and heart failure with reduced ejection fraction. If you go back to the prior slide one more time, sorry about that. So Jane wanted me to bring your attention to the fact that if you have patients that you think are eligible for this trial or any trial, you can send a staff message through Epic to research MHIF patient referral, and then that will be bird dogged out to the appropriate research coordinator, which is a nice tool that I didn't know about. So, you know, I think if they have an alternative, maybe if they have a pulmonary vein stenosis, I don't know, maybe Peter, you can speak to this for the alt flow study.
It's a shunt between the coronary sinus and left atrium. Left atrial thickness can be a contraindication, and coronary sinus diameter. So it has to be anatomically deliverable. So that is one that's a little tougher in that respect. That's also, as you alluded to a little earlier in its development, so they're a little more persnickety about the anatomy of it.
Right. Okay, well, thank you for being here this morning. I'm going to be talking to you about cardiac contractility modulation. And when I agreed to do this grand rounds 9 months ago, talking about heart failure pathophysiology after being on call in the ICU for 48 hours, seemed like a great idea. So here I am. I have no financial disclosures. I do want to mention that there's presently only one manufacturer that makes this device and has this technology. And I also want to draw your attention to a Nature Reviews Cardiology review that I participated in writing back in 2013, mainly because it's a useless document now, because our understanding of how this technology works has totally evolved over the last 6 years since I wrote that. So we know that we have excellent therapies for heart failure that have been very well studied and improve mortality and morbidity in heart failure. And we know also that these are, woefully underutilized, both heart failure pharmacotherapy and some other therapies as well. But even when they're aggressively utilized, we know there's a big divide between people who are optimized on goal-directed medical therapy and the symptoms they're often left with in terms of activity intolerance and advanced heart failure therapies. So there's this big divide, lots of patients who are kind of the walking wounded heart failure patients who continue to have heart failure symptoms, but are probably not eligible or shouldn't be directed towards advanced therapies. And over the last few years, we've had a proliferation of new therapies in heart failure. Whereas goal-directed medical therapy is kind of homogenized treatment of systolic heart failure where everybody gets the same treatments regardless of what your underlying pathophysiology is, these therapies are probably not well to be applied to everybody. And so understanding where these things fit in is complex and will rely on us more precisely defining the physiology of the patients we're taking care of. And I think this kind of concept of how we've homogenized the management and study of heart failure patients and the need to better phenotype heart failure patients was really nicely drawn out in last week's issue of JACC in the echocardiographic subset of patients from the Paragon trial. This was the trial of sacubitril valsartan in patients with preserved ejection fraction. And the associated editorial draws out the fact that we failed to find therapies for HFpEF in part because we've lumped a bunch of unlike patients together. And actually, when we look more closely at these patients, there's unique subsets of pathophysiology. So understanding more precisely the pathophysiology and then understanding how these therapies work is going to be critical to knowing where to apply these treatments. So you can think about cardiac contractility modulation through that lens when we talk about it today. And cardiac contractility modulation is basically non-excitatory stimulation applied to the myocardium during the absolute refractory period. So it's a current or voltage pulse, and this is what the surface electrocardiogram looks like, that's precisely applied in terms of timing to the myocardium at a time when the myocardium is refractory to excitation. And in doing so, it elicits an increase in contractility. So the initial concept is actually comes from something we've all observed either in the ICU looking at a monitor, or if you've palpated the pulse of a patient who's having lots of PVCs, and that's the idea of post-extrasystolic potentiation. So when patients are in sinus rhythm, we know that extrasystolic beat, the PVC, especially if it's closely coupled, doesn't generate a lot of contractile force. You really can't feel that usually. It's the post-extrasystolic beat where there's intensified systolic force production. And this was observed all the way back over 130 years ago by Oscar Langendorf and described in a manuscript. And over the decades that followed, we began to understand the physiology of post-extrasystolic potentiation, and it has to do with the excitation-contraction coupling that occurs in the cell. So we know when the myocyte is depolarized, the first thing that happens is a small amount of calcium enters the myocyte through the voltage-sensitive L-type calcium channel. And this small amount of calcium influx then triggers a much larger amount of calcium release from the sarcoplasmic reticulum from the ryanodine receptor. This is a process called calcium-induced calcium release. And that amplified calcium influx into the myocyte provides the bolus of calcium that allows for contraction coupling and contraction to occur. We know that relaxation is an active process, so circa 2A, the sarcoplasmic reticulum calcium ATPase is what sequesters that calcium back in the sarcoplasmic reticulum. And then the sodium-calcium exchanger also extrudes calcium from the cell. So this process is how we have excitation-contraction coupling. So what happens in extrasystolic and post-extrasystolic beats? So at rest, you have a certain amount of calcium flux. In the extrasystolic beat, the ryanodine receptor is refractory, so you don't have calcium-induced calcium release. So you have less calcium in the cytosol, but calcium still getting sequestered inside of the sarcoplasmic reticulum. So on the next beat, the post-extrasystolic beat, you have a sarcoplasmic reticulum primed with lots of calcium and ready to generate a big influx of calcium. So you have this higher intracellular calcium flux is what induces that increased contractile state. And there's these two properties of post-extrasystolic potentiation, mechanical restitution and post-extrasystolic potentiation. And basically that's telling us as you get increase the extrasystolic interval, so make the space between the PVC and the regular beat increase, you have increased contractile force of the extrasystolic beat and decreased contractile force of the post-extrasystolic beat. So there was a lot of interest in thinking about could you externally depolarize myocytes in order to elicit this inotropic effect in an exogenous way. And the person who was most instrumental in forwarding that theory was Earl Wood. And Earl Wood was a cardiopulmonary physiologist and kind of a giant in the field of cardiopulmonary physiology. He spent his early career at Mayo in a secret government program using this human centrifuge. So he was assigned the task of studying the loss of consciousness that occurs in, at that time, fighter pilots when they experienced high G-forces. And he set up this lab and was also one of the primary test pilots. And here's on one of the many runs where he was induced loss of consciousness. And what Wood was really famous for was his very elaborate techniques at measuring the physiology and developing equipment to precisely understand the physiology of this process. So he created a lot of technologies in doing so that ultimately led to the development of what this gentleman's wearing, which is the G-suit. So the G-suit helps prevent the loss of consciousness by decreasing venous pooling in the legs. He also developed a breathing technique you can see him demonstrating in the bottom right, which in combination, these two allowed pilots to maintain consciousness during evasive maneuvers. And actually, this was in the early 1940s, gave Allied pilots a strategic advantage in their flight. But Earl Wood, we know today for all of his many inventions. And spending the weekend in the ICU, I used lots of these. So the arterial line and the fluid-filled transducer, the pulse oximeter. He was one of the fathers of using the indicator dilution method for assessing cardiac output. And we know him today for his work in assessing pulmonary vascular resistance with the eponymous Wood unit. He also developed the multi-channel signal recorder. So when we have an ICU monitor or monitor in the cath lab, that's in large part thanks to Earl Wood. Subtraction angiography, and actually late in his career was one of the forefathers of the multi-slice CT. But more germane to this talk, Wood was a master at using this device called the voltage clamp for studying the effects of external electrical stimulation of isolated myocytes. And he started his experiments by asking the question, if I depolarize this piece of myocardium, can I induce the increase in contractile force that we see in post-extrasystolic potentiation? So they exposed this myocardium to a depolarizing current and elicited a contracture, so tetany of this piece of muscle. And they saw that the first beat after contracture did exhibit this increase in contractility, and that decayed over the subsequent 8 beats. But that's not very helpful because you can't really do that to obviously if you do that to a intact human heart, you arrest the patient. So he wanted to know if you expose the myocardium to sub-threshold depolarizing currents, could you elicit the same response? So these are not actually causing contracture of the myocardium. You're just exposing the myocardium to this sub-threshold current. And yes, in fact, you do exhibit increase in contractility when you do that. And most importantly, for cardiac contractility modulation, he showed that if you expose the myocardium to discrete pulses, 50 milliseconds in duration, precisely when the myocardium is in the absolute refractory period, it can't be stimulated, you still elicit a contractile response. It's smaller than when you have sustained depolarization currents, but it's actually something that could be, in theory, applied to an intact human heart. We know in heart failure, all the things we talked about for intracellular calcium hemostasis are deranged. The L-type calcium channel is downregulated. The ryanodine receptor is downregulated. SERCA2A is downregulated. The sodium-calcium exchanger, which is the thing you don't want to have upregulated, is upregulated and gets calcium out of the cell. So in the early 2000s, investigators started to say, well, maybe we can start to harness Wood's findings and apply them to hearts in heart failure to elicit a positive inotropic response. So these were studies done in the early 2000s where they used now calling it cardiac contractility modulation. They used small current impulses of 2 milliamps. And these are studies that were done in isolated papillary muscles. And they saw, again, when you used this cardiac contractility modulation, you saw a large increase in systolic force production. Highlighting the fact that it was related to calcium is when they gave ryanodine, which blocks the ryanodine receptor and inhibits that calcium-induced calcium release. You abated much of that response. And these signals had some interesting properties. If you increase the duration or amplitude of the CCM impulse, you generated more systolic force. And interesting, if you reverse the polarity and use the negative current to hyperpolarize the membrane, you had a negative inotropic effect. And these forces were additive to inotropes, and importantly, they weren't abated with beta blocker therapy, unlike catecholamines, where you neutralize the effect of the increase in contractility by giving a beta blocker. So this was the first study in an intact human heart, where again, this was using a biphasic current pulse. And again, you see an immediate increase in left ventricular pressure and dPdt, the change in pressure with time. So 2 metrics of contractility. And this study is really echoing a kind of seminal study by Johns Hopkins looking at the first kind of hemodynamic study looking at cardiac resynchronization therapy in patients with left bundle branch block. You turn on CRT in a patient with left bundle branch block, you see an instantaneous hemodynamic response in a subset of patients. And so this was essentially showing the same thing with cardiac contractility modulation. One way we, in a research setting, investigate contractility is by doing what's called preload recruitable stroke work. So there's a balloon in the IVC that is inflated, creates a declining amount of preload of the left ventricle, and each of these declining preload pressure volume curves is done in a series, and this line that connects these points is the end systolic pressure volume relationship, or a measure of contractility. So they did these studies in cardiac contractility modulation in intact hearts, and what you see is the stimulation that's provided to the anterior portion of the myocardium seems to elicit a bigger increase in contractility. And when you stimulate both the anterior and posterior walls, you get the largest increase in contractility here. So that's great. We can increase contractility by increasing cytosolic calcium. And we already know how to do that with what we call calcitropes. Those are the inotropes that we conventionally use, which all work by increasing cytosolic calcium. So the catecholamines, milrinone, even levosimendan, which we don't have in the United States but is used in Europe, all work in part by increasing cytosolic calcium. And we know they're great and effective drugs at increasing contractility, but we also know they increase myocardial oxygen consumption and they increase mortality. And we know a lot about all the ill effects of using inotropes. And probably the most hazardous effects are the increase in myocardial oxygen consumption and the neurohormonal activation that comes with using these drugs. So whenever we look at any therapy that works by increasing contractility, it's critical to demonstrate that it does so without increasing myocardial oxygen consumption. And this was looked at in 2 ways in CCM. The first was looking at the acute stimulation. So this is a study where they invasively measured myocardial oxygen consumption. And the way that's done is you need to know the AV oxygen difference. So they measure oxygen concentration in the coronary artery and in the coronary sinus, so they can see the amount of extraction of oxygen in the myocardium. And they do quantitative coronary angiography to measure how much blood is going into the heart. And when you do these studies, they can see that the increase in dPdt that comes with CCM acutely, which looks like it's about 15 to 20% improvement in contractility, is achieved without any increase in myocardial oxygen consumption. The same is true of cardiac resynchronization therapy, but is not true of inotropes, which increase myocardial oxygen consumption. So that showed us acutely in the lab that over a short period of time there wasn't an increase in myocardial oxygen consumption. But investigators wanted to go a step further and show that a longer-term support with CCM didn't result in increased myocardial oxygen consumption. And the way they did that is with a non-invasive measure of myocardial oxygen consumption using C11 acetate PET scanning. And the concept there is that acetate is a good perfusion tracer. It goes straight to the myocardium as a perfusion tracer does, but then it becomes locked in the myocardium as acetyl-CoA unless it's released by getting incorporated in the Krebs cycle oxidative phosphorylation, an oxygen-dependent process to be eliminated as carbon dioxide. So the uptake of acetate is used as a perfusion tracer, but the elimination of acetate from the myocardium is how we assess how much oxygen consumption is occurring in the myocardium. The more rapidly it's eliminated, the more oxygen consumption is occurring. And so using these techniques, again, if you look at dobutamine, there's a substantial increase in myocardial oxygen consumption. Cardiac contractility modulation has a negligible effect on that. We have evidence that cardiac contractility modulation increases the phosphorylation of cardiac myofilaments like troponin, and that's an important, the phosphorylation makes these myofilaments rather more responsive to calcium, and so that's important for eliciting their contractile effect. And then I'm going to quickly move through these slides and just summarize by saying in studies using myocardial biopsy to look at gene expression patterns in the myocardium, what we know is that acutely there's changes that occur locally, but over time, over several months, the same change in the up and down regulation of important genes in terms of reducing heart failure morbidity occur throughout the myocardium. So if you do biopsies of the heart at remote sites 3 months after starting cardiac contractility modulation, then some of these important calcium regulators are upregulated in sites distant from where you're actually stimulating, which is an important part of how these work. So acutely, the genetic changes seem to occur locally. Over time, they get disseminated throughout the myocardium. And it appears that happens through gap junctions. So we know that regulatory microRNAs can go through gap junctions. There's lots of gap junctions in myocytes. That's how they allow electrical conduction. And so this is in part how these genetic changes get disseminated throughout the myocardium in what's called a source-sink relationship. So the CCM pulse locally creates a source of favorable pro-survival factors and a sink for pro-apoptotic factors. So this is how we think these signals get disseminated throughout the heart. There's evidence that CCM reduces myocardial fibrosis, again in a biopsy study. And then important effects on the sympathetic and parasympathetic nervous systems, which we know are important in the progression of heart failure and interact with the renin-angiotensin-aldosterone system. We know that measures of autonomic balance independently predict survival in heart failure with reduced ejection fraction. I'm just going to skip through this in the interest of time. And now there's a lot of interest in looking at devices that can rebalance autonomic, rebalance the parasympathetic and sympathetic nervous systems. And you hear some about these, but for the most part, these have been disappointing when studied in clinical trials. The vagal nerve stimulator is kind of the one that's been most actively studied. And there's a lot of challenges with these trials that are, impact the study of something like cardiac contractility modulation too. Namely, we don't have really good physiologic biomarkers that are easy to measure for the autonomic nervous system. And when you think about it, it's very easy to understand how you would dose something like cardiac resynchronization therapy. You turn it on, you want to get 99 or 100% biventricular pacing. You can look at the QRS complex after you start CRT. But how do you gauge the proper dose for a vagal nerve stimulator or CCM? What's the right voltage? What's the duty cycle that's best? What location should you apply the the stimulus in and for how long. And so these things are very complicated to assess. And then finally, knowing whether you stimulate the afferent or efferent nerves, so the nerves that take autonomic signals back to the central nervous system or back out to the tissues. And the key trials in vagal nerve stimulation have been disappointing. I'll just summarize it in that way. Spinal cord stimulation has been similarly disappointing, and renal denervation, which Dr. Wong spoke about for refractory hypertension, is also an area of investigation. Cardiac contractility modulation impacts the parasympathetic nervous system in a way that's related to the basal gyrus reflex. So you remember the basal gyrus reflex is you stand up, blood pools in your legs. It elicits a response from the baroreceptor that elicits strong contraction of the myocardium. And that contraction is sensed by mechanoreceptors in the heart that take a parasympathetic impulse to the central nervous system and cause bradycardia, hypotension, and in a similar way, when we stimulate the myocardium to contract more vigorously with CCM, we send afferent signals through the vagal nerve back to the central nervous system, and this upregulates the parasympathetic nervous system and downregulates the sympathetic nervous system. So it rebalances the autonomic tone in the heart in a way that's different than other neuromodulation therapies, which do one or the other, but not both. Investigators looked at this and they saw when they stimulate with CCM, you can actually measure the firing frequency of the afferent nerves going back to the central nervous system in the vagal nerve, and you can see an increase in firing frequency when you stimulate. So direct evidence that stimulating does turn on afferent signals back to the central nervous system. And interestingly, the same effect is seen if you do non-excitatory stimulation of the stomach. When the stomach is contracting, if you stimulate it with non-excitatory stimulation, you see that same increase in afferent conduction in the vagal nerve. So this is something that's not unique to the heart. So the preclinical findings, just to summarize, there's an increase in systolic force, and that's without an increase in myocardial oxygen consumption, so differentiating it from catecholamines. There's an increase in intracellular calcium metabolism. There's an increase in phosphorylation of myofilaments. There's a molecular remodeling that occurs to a more favorable gene profile. And these effects are propagated throughout the myocardium. They're not localized to the site of stimulation. There appears to be a decrease in fibrosis, and there appears to be a rebalancing of autonomic tone. So looking at the clinical data, the current device uses a double biphasic voltage signal that's seen here. This is the equipment that's currently out. This is the optimizer, which is the main device that's been studied. You can see there's 3 leads, an atrial lead and 2 ventricular leads. So there's a right ventricular lead that functions as the lead that provides the signal, and there's a local sense lead that assists with timing. And you can see these a CCM device in a patient with an existing ICD. Importantly, the device is powered through transcutaneous energy transfer through an inductive coil that has to be charged for 40 to 60 minutes weekly. And the device doesn't continuously provide these signals. It gives 5 non-continuous hours of CCM therapy timed usually overnight. And one of the problems with this therapy is that we don't really have a good dose response curve. For some of the reasons I talked about when talking about other neuromodulation therapies, it's very difficult to know where to start. You know, there's so many variables, and how do you know what the right amount of stimulation is, and the duration and the current or voltage necessary. So that's a limitation of these studies. To date, about 1,600 patients have been looked at. The first few studies really were to establish safety, with a special attention towards arrhythmic complications. And throughout all of the studies, the signal of safety is strong. There doesn't seem to be any increased risk of arrhythmias. And the complications of device implantation, I think, are in the range of what's seen with other implantable electronic devices. The first important clinical study was FIX-HF4. That was a randomized, double-blind study, which was a crossover study. So everybody got implanted with a device. This was in patients with EF of less than 35% and class 2 or class 3 heart failure. Everybody got a device. Group 1 in blue was on-off. So the device was on for the first 3 months and then off for the next 3 months. And the red group, group 2, had sham treatment, so the device turned off for the first 3 months and then on for the last 3 months. And you can see this is change in peak VO2. Interesting, both groups saw a similar increase in the first period and then separate in the second period. And similarly for quality of life metrics and 6-minute walk, we see that same effect. So there's this, even though one group had the device turned off and one on, at the first time interval, there's clearly a strong placebo effect. But these effects seem to separate in subsequent weeks. So there does appear to be a real effect there, but certainly have to separate that from whatever placebo effect is occurring. And this is the same study design that was used in one of the first really important CRT trials, Mustic CRT. And you can see comparing these two trials here, in group 1, where you had the device on and then off, it looks very much like Mustic CRT for both quality of life metrics and 6-minute walk. But in group 2, that's the off and then on, you can see CCM patients did experience this placebo effect. So why it was different than Mustic is unclear. There still seems to be an effect there, though. We see about a 5% increase in the ejection fraction. That, just like the genetic changes that happen throughout the myocardium, when we look at regional Doppler parameters, we can see that the increase in systolic function seems to occur everywhere, not just isolated to the site of stimulation. So FIX-HF5 was a larger study and looked at 430 patients, now with class 3 or ambulatory class 4 heart failure. And again, all these studies looking at patients with narrow QRS, so not CRT candidates. And here they looked at patients with ejection fractions less than 35%. All these trials mandated that people be on optimal medical therapy for at least 3 months prior to, or at least stable doses of medication for at least 3 months prior to being enrolled. And again, compared CCM to optimal medical therapy alone. Now, this was not a sham device or a sham procedure controlled trial, so people knew whether they had CCM or they didn't, which is a problem. We saw that there was a big placebo effect in FIX-HF4. The oversight committee for this trial didn't think it was appropriate to put a device in somebody that they'd have to simulate charging for months or years on end. So, but knew that they didn't have a good functional endpoint, because peak VO2, as everybody knows, is effort dependent. People can try harder or less hard, and so it's susceptible to a placebo effect. So in order to bypass that, they decided to look at the VO2 at the anaerobic threshold. So they look at the VO2 when patients cross from aerobic to anaerobic metabolism. That's a non-effort dependent endpoint. So, and the VAT, or ventilatory anaerobic threshold, is just at the VO2 when patients go from aerobic to anaerobic metabolism. And it's a good metric of sort of gauging activity of daily living, because most of the things we do on a daily basis aren't at peak exercise. They're at sub-maximal amounts of effort. And again, it should be not effort dependent. It should be the same no matter how much effort you put forth as long as you cross the anaerobic threshold. How do we measure that? Well, when you go from aerobic metabolism to anaerobic metabolism, you start to generate lactic acid. The lactic acid gets buffered by bicarbonate and makes water and carbon dioxide. So when you start to go into anaerobic metabolism, you start to make an excess of carbon dioxide relative to oxygen. And you can measure that by looking at the VCO2, the amount of carbon dioxide that's produced, and the VO2, the amount of oxygen that's consumed. And you see this inflection point, that's when you start to get this excess in carbon dioxide. Now, this is a really nice set of data here for this person. It doesn't usually look like this. It usually looks like a cloud of data. So this is it can be a problematic endpoint to look at in clinical trials. They did a lot of things to make sure they got optimal results, but still limited in its utility in these trials. When they looked at the group as a whole, they saw that the peak VO2, the VO2 at the anaerobic threshold was really unchanged between the optimal medical therapy and the CCM group. When they looked at the subset of patients that had ejection fractions greater than 25%, there was a difference there. One of the things I'll come back to in a few minutes is that you can see the magnitude of the difference is relatively small. It's less than 1 milliliter per kilogram per minute. But when you look at any clinical trial that is looking at peak VO2 or the ventilatory anaerobic threshold as an endpoint, even the most successful therapies really have these pretty modest effects. Just like CRT, CRT trials showing benefits in terms of ejection fraction or functional endpoints like VO2, the effect in the clinical trials is relatively modest. So important to keep in mind. I'm going to skip over that slide. So the signal from the FIX-HF5 was that the patients that derived the benefit had higher ejection fractions, not these really low ejection fractions. So the FIX-HF5C was a confirmatory study trying to prospectively confirm that finding. And these were the patients at baseline, most average age in the 60s, more men than women, more ischemics than non-ischemics, ejection fractions around 30% on average. And I'll draw your attention to the fact that the peak VO2 is quite limited. Peak VO2 of 15 for a 60-year-old is probably 60% to 70% predicted. So these are people with moderate degrees of activity and tolerance. And the study showed, again, a modest increase in peak VO2. Keep in mind all the problems with using peak VO2 that we talked about. Placebo effect, it's a effort-dependent endpoint. But with those issues in mind, there did seem to be a response that was sustained. So we would think that placebo effects for these patients, or at least the study, the authors suggest that placebo effects for peak VO2 seem to erode over time. So you may be able to kind of push yourself harder on the first studies, but as heart failure progresses, if you look at people over longer durations of time, it's harder to kind of manifest an improvement in functional capacity over long periods of time. Again, here, the higher ejection fraction patients did best. So EFs over 35%, they had the largest effect in terms of peak VO2 and the largest reduction in heart failure symptoms or the largest improvement in quality of life. Quality of life changes and New York Heart Association class changes here. Again, this is a non-blinded trial of advice therapy, so all of the potential biases that come into play there. But when you look in the totality of data, the changes in peak VO2 in cardiac contractility modulation trials is on par with what we see in CRT trials, even in the trials that were sham controlled trials. Investigators have drawn our attention to this, saying, these are, again, modest changes in terms of absolute change in peak VO2, but that's true of cardiac resynchronization therapy, a therapy we really think of as both improving survival with heart failure, but also improving symptoms. If you look at the subset of patients with ejection fraction over 35%, the peak VO2 changes are really more pronounced, as are these other changes. And this study looked at the composite endpoint of heart failure hospitalizations and mortality moving forward, and started to see the curve split, and this was driven essentially entirely by heart failure hospitalization. So there's a signal that there's a reduction in heart failure hospitalizations with CCM. The group from Bergmann Hospital looked at other changes that cardiac contractility modulation elicited in exercise activity. And these are two: exercise oscillatory ventilation and the ventilatory efficiency, or the ratio of ventilation and carbon dioxide production, are really important markers of risk and morbidity in patients with heart failure. In both cases, CCM resulted in improvements, so reduction in the amount of patients that had exercise oscillatory ventilation and an improvement in ventilatory efficiency. So I'll briefly tell you what those two parameters are, because I think they're important to understanding why people are short of breath with heart failure. So ventilatory efficiency is the ratio of minute ventilation to carbon dioxide production. So it's how much air you have to move to blow off a certain amount of carbon dioxide. Carbon dioxide comes to the heart with blood flow, so it's also a proxy for blood flow. And the amount of respiration one does is driven by chemoreceptors, central and peripheral chemoreceptors. So a certain amount of carbon dioxide triggers a certain amount of ventilation. And we can calculate the ratio. It's just a ratio of liters of ventilation to liters of carbon dioxide, and graph that out. Unlike peak VO2, this is totally effort independent. It's indiscriminate to the mode of exercise or the duration of exercise. You can plot out a line like this, but you can also pick out any point here and use that as the VE/VCO2. In heart failure, we have hypoperfused lung with lots of ventilation perfusion mismatch. The autonomic changes that happen with heart failure turn up the chemoreceptor, causing hyperventilation. And so we have high VE/VCO2 ratios, or inefficient lungs. So you have to breathe a lot in order to blow off the same amount of carbon dioxide. So the slope is steeper. And for the heart failure cardiologist, we know how the VE/VCO2 is a very potent predictor of survival in heart failure. And it's also often correlates with activity intolerance as good or better than the peak VO2. Exercise oscillatory ventilation is just what it sounds like. It's oscillations and ventilation with exercise. This is the cardiopulmonary exercise test analog of Cheyne-Stokes respirations, or central sleep apnea. So periods of hyperpnea, so breathing a lot, or hypopnea, not breathing a little. And you can see in these, when we look at the raw data here, these oscillations in ventilation. And these two features together have portend a very poor prognosis in heart failure. In fact, exercise oscillatory ventilation is the strongest predictor of survival of any measurement we make on a cardiopulmonary exercise test, more than the ventilatory efficiency, much more than the peak VO2, which is actually a fairly poor discriminator of survival when you compare it to these other two. And that's almost entirely driven by the effect by the measurement of sudden cardiac death. So again, maybe having to do with the fact that exercise oscillatory ventilation is a reflection of autonomic dysregulation, and that also carries with it a risk of sudden cardiac death. So to summarize these things, when the heart failure is bad, you have reduced cardiac output, circulatory delay, and changes in chemoreceptor activity. And these things enhance ventilatory drive inappropriately. You blow off the carbon dioxide and then have episodes of hypopnea. And it's this cyclical changes of hyperpnea and hypopnea. This is exactly what underscores Cheyne-Stokes respirations and central sleep apnea in heart failure patients. At the same time, you have pulmonary congestion. poor perfusion and ventilation perfusion mismatching, and again, overactive stimulation of the ventilatory drive. That gives you lots of ventilation with relatively little CO2 delivery and that ventilatory inefficiency that comes with heart failure. So these are two very important endpoints or metrics that we look at in heart failure patients. And CCM can impact these in a lot of ways, mainly through how it augments autonomic tone and enhances contractility. There's a European registry looking at cardiac contractility modulation. They saw, again, this is registry data, they saw a dramatic reduction in heart failure hospitalizations of roughly 75%. So you can see the event rates pre-enrollment and event rates post-enrollment. And they looked at survival relative to the Seattle heart failure model, which is obviously a very problematic way of grading survival in a study, but they saw in patients with ejection fractions of 35 to 45%, their survival up to around 1,100 days outpaced the survival that would be predicted by the Seattle heart failure model. But again, not a replacement for a well-conducted clinical trial. They saw sustained improvements in functional class, quality of life, and ejection fraction. So to summarize the clinical study findings, after the initial blinded crossover study, the trialists have really abandoned the idea of a sham-controlled trial in HFrEF, which is, I think, a problem and a limitation in the results that we have to look at so far. We know that there's clearly a placebo effect and maybe this Hawthorne effect, so the fact that study participants change their behavior knowing they're being studied and improve their exercise capacity even though we didn't do anything to them. Quality of life metrics, for the same reason, are difficult to assess. You know, how much stock do you put in a Minnesota Living with Heart Failure questionnaire if the person knows they have the device or knows they don't have the device. That said, I think there is a clear, the culmination of the data suggests there's a clear increase in exercise capacity, both with the peak VO2 and the ventilatory anaerobic threshold that's comparable to what's seen in CRT trials. And there is an increase in left ventricular ejection fraction. And importantly, there seems to be this improvement in ventilatory efficiency and instability. Whether or not there's a reduction in heart failure hospitalizations and has any impact at all on survival, we don't have data to support that really in a conclusive way. The FDA gave it expedited access pathway in 2018, acknowledging that this was an underserved population, people that are not CRT candidates, that have ongoing symptoms, not bad enough to get a VAD, but still displeased with their quality of life. And in March of 2019, it was FDA approved for EF 25 to 45%, class 3 or ambulatory class 4, and again, not a CRT candidate. So I think that my impression is interesting results, certainly something we like to be participating in clinical trials, particularly one that I'll mention in a second, but difficult to want to enthusiastically recommend this to lots of patients. Now, there may be a subset of patients that are really struggling with ongoing symptoms of heart failure that this could be thought of as an option. But the trial that I'm very interested to participate in is the study looking at heart failure with preserved ejection fraction. A lot of the pathophysiologic impacts that we talked about in the preclinical studies are particularly important in HFpEF. And all the trials to date have seems to show the signal that the higher the ejection fraction, the more the benefit. So this is actually, I think, going to be a good trial because it's randomized, it's going to be blinded, it's going to be a on-off trial for 1 year of follow-up. So everybody's going to get the device, and so that will hopefully deal with some of the limitations in the other clinical trials. It's going to have a 1 year endpoint, and it's going to look at CV mortality and heart failure hospitalizations. So that's a trial that's currently being developed, and the heart failure group and EP group have been in communication with the device company and would really like to participate in this study. There's concerns we have. We don't have the kind of data that cemented the enthusiasm and CRT. You know, the CRT was FDA approved with maybe a similar kind of data that we have for CCM. But the reason we use CRT all the time now is not because of those modest improvements in functional capacity that we're seeing in clinical trials. It's because of the impact it has on long-term heart failure morbidity and mortality. We probably won't get the kind of quality data we want to see in heart failure with reduced ejection fraction. It doesn't seem like there's interest in doing those trials. But we will have that data for HFpEF, which I think is good. And this is a therapy where we can maybe say it improves functional capacity. Is it enough to say you have a therapy that improves functional capacity if we can't necessarily say that it improves your long-term survival? In the discussions that surrounded CCM, Clyde Yancey said, we can't do everything for every patient, which is true. We have all these new therapies in heart failure coming out. We can't use them all on everybody. You can't give everybody an SGLT2 inhibitor and Entresto and an atrial shunt and cardiomems. And so we have to start to be more selective in picking which patients are best treated with these therapies. And there is a logistical problem that can come up with putting these in. We already have a limited amount of subclavian real estate in patients with already having devices like ICDs, and so we have to be judicious about potentially impacting that. But there may be candidates out there, patients with class 3 symptoms despite goal-directed medical therapy. If there's a low anticipation of the need in the future for advanced heart failure therapies. And again, it seems like these higher ejection fraction patients are the ones that benefit most. So going back to the concept we talked about in the beginning of the talk, where do these things fit in? We don't have enough data yet to know where they fit in, but we can say probably with some certainty that this is not a therapy for everyone. Will we learn which patients do best with this? So the analogy to the MitraClip, for example, and the fact that we now have data that patients that have disproportionate amounts of mitral regurgitation to their degree of LV remodeling, that's the subset of patients that really does well with the MitraClip. Those are the COAPT patients versus the Mitra FFR patients. So we need to have the same kind of data for driving other things we do. And there's lots of heterogeneity in these patients. And so is there going to be a group of maybe heart failure patients with mild to moderate reductions in ejection fraction or mid-range ejection fractions? And maybe we'll have some other markers that can identify which patients will benefit from CCM. We really don't have that data yet. And that's all I have to say. Thank you very much. Any questions? Jay?
Thanks for that, Mike. That was great. So it seems like the constant recharging of this thing seems like a real limitation. What is it about the battery or does it put out so much more energy? I mean, you have CRT devices that go years and years, and
it does deliver a lot of energy. So the pulse that's delivered is higher than what's typically used for pacing. But it's recharged once weekly through the skin. It takes about 40 to 60 minutes, so it's minimally detrimental to, it's not very intrusive. But yeah, so the battery we're told can last, but in theory for several decades, and so it's recharged through the skin. But the reason that what's driving the dose that's administered, the 5 non-sequential hours a day, is in part the need to recharge this thing periodically. So they're trying to balance that. But I don't think I think it's actually that's a nice thing about the device, not a downside of the device, is that you really don't have to replace the battery. For many people, will never have to have their device generator changed.
I agree. I think if you give someone a choice of having an ICD generator change every 5 years if they're 50 years old versus once a week put this and never worry about it, not take the 2% risk of infection every time you open the pocket. I wonder why don't they do it for other devices actually, if you think about it. But
Have we done any of these? And
No.
how technically difficult is it?
So I'll let maybe Manju and Raid speak to that.
It's technically difficult at all, just putting two pacemaker leads on the septum, one high on the septum, one low on the septum. The challenges are more along the lines of what Mike
How
said
much
about
more does
access and how many leads, and if someone already has an ICD, they used to require 3 leads to implant this device. They still, now it's meaning an atrial lead and 2 ventricular leads. Now they're moving towards just 2 ventricular leads. So actually it fits well if we really move towards patients with an EF more than 35% who don't qualify for an ICD or a BIV because they're an RQRS, then that becomes a much more intriguing and technically more
Well,
viable
and
business.
another possibility too is the, wireless CRT is another option that we can look at too. It's another way to
Yep,
minimize
that's,
leads.
Yeah, I don't know how much is there for patients with wide, the combination of CRT and
So
this.
there is data for CRT non-responders that this effect can be demonstrated in patients who are not responders to CRT with wide QRS complexes, but currently it's not approved for that indication. But we haven't done any of them, and there haven't been a lot of these done since FDA approval, and I think, I don't know the numbers exactly, but yeah, I think that for our kind of patients, the signal seems to be the really low EF patients, really advanced symptoms, really advanced remodeling we're not seeing a lot of benefit. You have to have some reserve there to augment contractility. And so I think this really going to be the mid-range ejection fraction patients and the HFpEF patients potentially that would derive the most benefit.
Mike has been working along with the foundation and the company and us in EP in figuring out how to put it on the shelf as far as supply chain, how to involve in clinical trials that are viable. And so there are a lot of effort going on as we speak, but it's, as you imagine, it's a complicated process to get into.
But it is approved, right?
It is approved.
So let's say if I want a patient, what do I do? Let's say, because I can see also older patients, like you said, 35, 40, let's say 72, 73. You don't really think they're gonna get to like a bad
Yeah.
candidacy, but they're still somewhat struggling. So I think that is, again, like.
Hopefully we'll, so Matt Ebling is working on the getting it available to us clinically. And then Carrie is working on, once we have that, we'll start to look at our participation in clinical trials. So we don't have it yet, but hopefully in 2020 we'll have access to it.
Mike, I really liked the physiology discussion. But what I don't understand is how does this process work without increasing myocardial oxygen consumption? What is the proposed mechanism that can happen?
So, the increase in myocardial oxygen consumption that comes with calcitropes, we don't think is necessarily related to intracellular calcium. We think it's all the other things that catecholamines do. They increase heart rate, they're sympathomimetic, they do other things with the autonomic nervous system that may be the main drivers of increased.
But it's independent of calcium.
So it appears that way because we know that these effects in CCM are mediated through, and in CRT, some of the effect is mediated through changes in calcium management in the cells, and neither of those demonstrates an increase in myocardial oxygen consumption. So yeah, that was actually one of the concerns early on when they thought increased calcium fluxes were responsible for the CCM effect. There was a lot of apprehension because people thought increased cytosolic calcium was the problem. But it's probably it's clearly more complicated than that, and it's maybe those heart rate issues that come with calcitropes that are driving a lot of that. And why it's so critical. Any of these studies that look at, I know Paul and Benson and some of us have been involved with the company and locally that's looking at parasympathetic plexus stimulation in the pulmonary artery. And one of the things everybody's told them is you have to do studies demonstrating you don't increase myocardial oxygen consumption, because any device or therapy that increases inotropy, that's the first kind of litmus test to know if it's going to be a safe thing to use long term. I don't know if that answers your question, Scott. I don't know. The real answer is I guess we don't really know, but that's the theory. questions? Thanks.
Just a reminder, I'll send out a reminder about the evaluation. If you haven't filled that out yet, please do. And then we're taking a 2-week break for the holidays. This is the last one for 2019. And we'll be back January 6th. Thanks.
I thought that was very, very important.